Presenting information for community development for suicide prevention in older adults. Presenting the following information will be
Mariah,
Krista,
Lydia,
and Monica.
After this presentation, viewers will be able to identify the different levels of suicide, identify current and future intervention trends, identify risk factors and predictors of suicide, and identify resources for further help. The risk factors and predictors will be briefly recapped as they were covered in a previous training video.
There are 3 different levels of suicide prevention. Universal prevention aims at reducing the incidence of new cases in entire populations, such as a national or local community, typically through information and skills enhancement. Selective prevention focuses on high-risk groups that generally display no advanced signs of suicidal thoughts or behavior, but are exposed to important losses and life transitions that can make them vulnerable to depression and suicide, such as the very old and highly disabled, the recently retired or bereaved, or those who suffer from painful chronic illnesses. This type of prevention is typically aimed at reducing risk predictors or improving resilience. Indicated prevention aims at individuals who clearly exhibit suicide risk behaviors, such as those who have a psychiatric illness, who express wishes to die or suicidal ideations, or who are at imminent danger of attempting suicide.
Some predictors of suicide in older adults are unemployment. Unemployment is difficult because the older adult is involuntarily unemployed, and this may create negative mental health and financial consequences for the older adult. Lack of stable income can be a predictor for older adults because there is no financial freedom. There is a pattern of older adults having medical illness and medical contact within 3 months prior to their suicide attempt. Self-reported depressive symptoms is one of the strongest predictors of suicide. Older adults tend to attempt to commit suicide 1 week after at least one of the risks above. Older adults have a significant increase of suicide when compared to any other age group. But why? What are some of the risks and cues to look out for? Suicide in older adults is a highly neglected area, and there is a lack of basic knowledge about older adult suicide among clinicians. Older adults will first confide in their primary caregiver, who also aren't extremely qualified for this topic, rather than a mental health professional, which is a huge issue due to the rates at which suicide happens. The absolute number of suicide among older adults is expected to increase, so successful early identification and interventions is vital for older adults getting help, and this process begins with knowing and being able to identify the risk and predictors. A few are: the older adult has a psychiatric disorder, such as depression, physical and chronic illnesses, and they are a risk factor that often are comorbid with mental health concerns, functional impairment, stressful life events such as divorce, widowhood, or recession, hopelessness, and social isolation.
Some current interventions include primary care, which is receiving support from depression care managers who offer education about treatment options, brief psychotherapy, and provide close monitoring of depressive symptoms and medication side effects, as well as a follow-up on patients. A key part of IMPACT, which stands for Improving Mood, Promoting Access to Collaborative Treatment for Depression in Primary Care, is the use of a personalized treatment plan that includes patient preferences, as well as a proactive follow-up by a depression care manager. A care plan tailored to the patient can actively engage older adults in treatment for depression, increase self-efficacy, and increase confidence in managing depression. This intervention provided a statistically significant result of lower depression and suicidal ideation, as well as greater quality of life and reduced functional impairment. The PROSPECT, which stands for Prevention of Suicide in Primary Care Elderly Collaborative Trial intervention, also included care management, but only statistically benefited those with major depression who had lower levels of active suicidal desire. Community-based outreach programs typically included mental health workshops for older adults to promote awareness of depression and suicide risk. The programs also included annual depression screenings of all residents over age 65, with positive results being followed up by a clinical interview with a psychiatrist. Other programs included group activities to reinforce social support, but those programs only produced a significant reduction in suicide rates for females. Telephone counseling consisted of a telephone service, which was telehelp, a 24-hour emergency service for older adults to call for help, and telecheck, a twice-weekly telephone support. This intervention also had a positive impact on clients' psychological functioning via reductions in depression scores, hospital admission, and requests for a home visit by general practitioners. But there was only a significant improvement for women, though the study was 84% women. Clinical treatment included depression treatment using pharmacotherapy and in some cases included interpersonal psychotherapy sessions, or IPT. After 12 weeks, participants' suicidal ideation had resolved, and this was in all treated patients regardless of treatment assignment. But patients with higher suicidal risk needed longer time to respond to the treatment. One resilience training program included an 11-week workshop which was offered to small groups of early retirees who had problems adapting to retirement. It aimed at increasing meaning in life by helping participants set, plan, pursue, and realize meaningful, concrete personal goals. The other program provided a 16-week interpersonal psychotherapy for adults over 60 years at elevated risk for suicide to improve their social functioning and skills in order to enhance social support and satisfaction of interpersonal needs. Those in this treatment group showed a significant decrease in depressive symptoms and in their score on the geriatric suicide ideation scale. Cognitive behavioral therapy that is focusing on reducing suicidal ideation and risk factors in later life, rather than only reducing depression, can better reduce rates of suicide in older adults. Therapists can provide recordings or transcripts of sessions to better assist those who might have memory impairment. While in therapy, having patients construct a hope kit helps lower feelings of hopelessness and helps them identify reasons for living that they failed to identify previously. A hope kit includes meaningful mementos that can be reviewed in times of crisis, such as pictures, postcards, letters, and inspirational or religious sayings or poems. Most current programs address risk predictors, but programs aiming at improving protective factors are still rare. Intervention strategies that enhance positive aging and quality of life by increasing empowerment, coping, and adaptive behavior, social skills, self-esteem, and many other traits could be innovative and promising ways to prevent suicide in older adults. The previous training video noted that men are at an increased risk of suicide. Because of this, and the fact that current interventions work best for women, it is increasingly important for future interventions to focus on reaching out to men. Older men are less inclined to seek medical advice and can prefer intervention programs that focus on action and problem solving rather than the expression of emotions or creating new relationships. Men prefer structure in therapy, focusing on individualized goals and expected progress, establishment of trust, and a sharing of decisional control. Men are also less likely to be referred to clinical treatment as they express their depression symptoms atypically, such as with outbursts of anger. So to better find and treat men who need help, we should address attitude barriers by de-emphasizing labels of depression and focus on symptoms and stressors instead. Training community gatekeepers to be able to detect depression or provide annual screenings for suicide and depression could help. Widening what issues are included in risk assessments would also help, such as those frequently faced by suicidal older men, like involuntary retirement, pain, dependency, daily hassles, sleep problems, loss of driver's license, bereavement, and alcohol abuse. New programs should reach out to family members, friends, and caregivers. They could have valuable insider info about life experiences and suicidal risk that healthcare providers might not be aware of. Using telecommunications to expand education and support, as well as detection and treatment of mental illness, could also improve treatment and identification of depression and suicidal symptoms. Having round-the-clock access to a therapist creates a lifeline that could increase feelings of security. Seeing a primary care physician frequently and regularly to monitor adherence to the prescribed regimen, response to treatment, and offer support to address sources of distress could also improve outcomes. Painful chronic illnesses or sleep disorders are associated with suicidal ideation, so physicians should pay attention to these difficulties as part of the investigation of possible suicide risk.
One of the biggest issues with current interventions is finding ways to get older adults to reach out to help. Research shows that when recruitment strategies are based on collaborative relationships between caregivers and patients, they are most effective. Some side effects of this are encouraging active and healthy aging for the older adults, improving their security and social support systems, having more adequate training in geriatric care professionals, promoting good mental and physical health for the older adults, having good community programs to help with the security and social support, and educating the people that are in the community. One of the biggest parts of suicide prevention is improving the quality of life. Asking the patients to list their reasons for living can be an effective way to help them to see that their life is still meaningful. This can be done by building a memory box or a hope box, which was mentioned in a previous training, how you might have the patient do this. Building a support system is also helpful because it keeps them engaged in their life. Improving their problem-solving skills can be done by asking the patients to catch their negative automatic thoughts, check their empirical basis, and change their beliefs accordingly. Then finally, scheduling activities to help just keep their lives active and healthy and more full and happy.
For further information on the topic and help, we included some national and local resources. The National Suicide Prevention Lifeline provides 24/7 across the United States free and confidential emotional support to people who are in a suicidal crisis or in emotional distress. In addition, the website provides prevention and crisis resources. The American Association of Suicidology is an organization that aims at understanding and preventing suicide through education, research, and resources. The website includes statistics and tools, current research, and information for people who have lost a loved one to suicide and people who have survived suicidal behavior. The American Foundation for Suicide Prevention is a nonprofit organization that is dedicated to understanding and preventing suicide through research, education, and advocacy, and that is dedicated to reaching out to people with mental disorders and those who are impacted by suicide. Phone polls provide seniors, homebound individuals, and those with disabilities companionship by regular phone calls with the aim of decreasing social isolation and loneliness. They also provide assistance with navigating healthcare, insurance, care planning, and other common needs of older adults. In the local area, the Mental Health First Aid Missouri is an 8-hour course that teaches participants how to help someone who is developing a mental health problem or who is currently experiencing a mental health crisis. The Access Crisis Intervention Hotline provides 24/7 help, guidance, and services in crisis situations by mental health professionals from the Missouri Department of Mental Health. And finally, the Ozarks Counseling Center provides mental health services to the community and bases counseling fees on a sliding scale that takes annual income and household size into account.
Now it's time for you to see what you've learned. Here are some quiz questions to see if you've paid attention today. What is a risk factor leading to suicide attempts in older adults? Is it A, psychiatric disorders, B, no risk or predictors, C, being active or exercising, or D, eating more? The answer is A, psychiatric disorders.
What are the 3 levels of suicide? A, first, second, and third. B, primary, secondary, and tertiary. C, universal, selective, and indicated. Or D, none of the above. The correct answer is C, universal, selective, and indicated.
Name 2 current or future interventions. A, telephone counseling and journaling. B, going to the beach and taking a nap. C, community-based outreach and venting to a friend. Or D, primary care and clinical treatment. The answer is D, primary care and clinical treatment.
Who can older adults contact if they are seeking further help? A, no one. B, their therapist. C, Suicide Prevention Lifelines, Hotlines, Mental Health First Aid Missouri. Or D, their friends and family. The answer is C, Suicide Prevention Lifelines, Hotlines, Mental Health First Aid Missouri. And these are the resources where we got our information. Hopefully this presentation provided insight into the important topic of suicide prevention in older adults.